Good afternoon, everyone. Welcome to the SCCI presentation on protocol-based management for hypertension. So this presentation has three components. First, we will briefly discuss on the theoretical components of hypertension, how to measure blood pressure, and the second part is the protocol for hypertension that has been updated in January 2025 this year. Coming to the definition of hypertension, it is a state of elevated blood pressure, and then that high blood pressure is detrimental to health. Now, three ways to measure blood pressure. One is office blood pressure, when a patient visits to your office or your hospital, and what you measure is for your office blood pressure. The second one is 24 hours ambulatory blood pressure, where you wear the pressure cuff and the pressure machine for 24 hours, and then at the end of it, 24 hours, you'll have a graph that shows the systolic, diastolic, and other features with which you will tell, and you can, based on which you will classify whether the patient has hypertension or control rate. The third one is what is called as home monitoring of blood pressure, where now it's encouraged that patients can have a blood pressure machine at home and then measure the pressure on their own. For the classification of hypertension, this is what the International Society of Hypertension says, and then normal blood pressure is less than 130 by, here it gives us 85, but in our protocol, we have adopted another cutoff. And this basically says as the pressure goes up, you go to a higher grade of hypertension, and this is directly linked to the how fast you develop the complications associated with hypertension. Now, how do you really establish that a person has hypertension? This requires 2 to 3 office visits. It means that you cannot make a diagnosis based on one reading, and it has to be at an interval. So the standard interval recommended is 1 to 4 weeks interval. This means that we conduct a lot of screening for hypertension, and then if it was the first reading that's recognized to be high on that screening any instance, you can never label it as hypertension unless it is more than 180 or 110 and with a cardiovascular risk factor. Now, we have a couple of instruments that will help us measure the blood pressure. And the first one is a sphygmomanometer. It initially used to have mercury in it, but now it's replaced by some other material. But this instrument measures your blood pressure directly. The second one is your aneroid manometer. This also measures your blood pressure directly. But what we have most commonly now in the hospitals is this kind of a digital machine. And it is called as a digital BP meter because it does not measure the blood pressure directly. So it measures what is called as the oscillations as the blood passes through the arteries, and then through an algorithm converts it into a number. This means that it comes with a lot of caveats when you interpret it. First thing is that your machine has to be standard, it has to be calibrated, your batteries or the cells have to be functional. So there are so many attributes that will determine whether or how accurate your reading is. Most important message through this is that in your hospital, there's something called as this. Every year, the team from biomedical engineering department will come to your hospital and then evaluate the health status of your machine, and then they'll do calibration. So when that cycle is there, please make sure that all your BP machines get calibrated. The next step here is to demonstrate how to measure your blood pressure correctly. First requirement is that it has to be a quiet room, and then it has to have a comfortable environment. Before the measurements, you should have stopped smoking and no exercise or no caffeine for the last 30 minutes. You make the patients wait and provide them a comfortable seat in your waiting room. They should have remain seated or relaxed for 3 to 5 minutes before coming onto the BP measuring your chair. And neither the patient nor staff should talk in between or during the measurements, and no texting, nothing like that. So the patient should be seated with a backrest, support the back. They should have emptied the bladder. They should have gone to the bathroom. The feet should be on the floor. It should not be crossing over another. So uncrossed leg, it should be on the floor. The arm can be a little flexed, and then the cuff should be at the level of your heart. The machine should be on the table here, and then this arm has to be supported. The other message is that No texting, no talking, no seeing the phone. And the other requirement is that the blood pressure cuff has to cover 1/3 of your arm from the acromion to the olecranon process. So it should cover the middle third. So some of the common mistakes that we do is that in our hospitals, we don't have chairs with backrest. The heights are not adjusted so that the feet are not touching the ground. And then sometimes the cuff are not in the middle 1/3 of the arm, and then it's over your elbow. So please make sure that you remind your staff, or whenever you do it, measure your blood pressure in the correct way. Now, after you have measured your blood pressure, based on your pressure readings, you will label it as hypertension or non-hypertension. But for everyone, you will provide what is called as interventions to address their risk factors. So risk factors are, we have the non-modifiable risk factors and the modifiable risk factors. Our key area of interest are in the modifiable ones, where you tell the clients to reduce excess salt. Then to stop alcohol consumption, to encourage physical activity, and then to reduce mental stress. Now, the reason why we need to diagnose hypertension, put them on medication if required, and follow up to treat that hypertension to target is because of the simple message that they are at risk of getting stroke, heart failures, chronic kidney disease, or hypertensive retinopathy. Now, how frequent do they get it? And then what is the relationship with these complications with hypertension is you can see in this table. Now, if you have higher blood pressure, you are at higher risk of getting the complications. But even if your pressure is not so high, but if you have this risk factors that we mentioned earlier in the earlier slide, if you have more risk factors, that you still have higher risk of getting complications. This means that a combination of high blood pressure and more number of risk factors, you are at very high risk of getting this organ damage. In terms of the protocol also tells us what are the goals of our treatment, and then we'll discuss all these things now. The goals, how to monitor, how frequent to monitor, what to communicate, we'll discuss it on our protocol. And some summary message is that for monitoring of complication for the heart, you can do ECG and look for features of left ventricular hypertrophy. For your kidneys, you can do serum creatinine level. And now with the electronic patient information system, the lab can make a click, and then they automatically give you the EGFR. You can check for urine protein or urine albumin. For the eyes, you do annual fundoscopy. And this is the message, health promotion message that is given on our Ministry of Health website. For those patients who are already on medication, please ensure that they are compliant to the medication. Then for the salt, reduce salt consumption to less than 5 grams. How do you advise the patients? For 5 grams of salt is half teaspoon. So this is a full teaspoon with mound on it. So if you make it flat on it, so this is half a teaspoon. So that will contain 5 grams, and then this can be distributed over your 3 curries that you cook in a day, or 2 curries that you cook in a day. So for 1 day, 5 grams of sodium chloride would mean half a teaspoon. Then eat a variety of vegetables, maintain your weight, and then when you're providing advice about physical activity, you contextualize. If a young individual would like to run, jog, you provide appropriate advice. If it's an elderly patient, or you can contextualize it by saying that you can do more of religious activities. And for tobacco and alcohol, DOMA, we say stop. And to reduce the mental stress, avoid mental stress, and then we advise on healthy sleeping patterns. The most important message, I think, through this slide is that you should address misconceptions. So our patients come with so many misconceptions. So you talk with them, and then do not confront, but tell it in a polite way, but address all the misconceptions. Now on, I will discuss on what is called the protocol that we have revised in January 2025. And this protocol-based management has been developed through the SCCI program and has been implemented in all the hospitals from November 2023 through an executive order. This protocol was initially, the protocol looks like this. It's one page. This protocol was developed by a couple of physicians, the program managers, we had experts from all various sectors involved in making the protocol, and then it went through many rounds of revision. This was reviewed by the experts at the World Health Organization in New Delhi, the Southeast Asia Regional Office. Based on the feedback, we made revision. We had implemented the first version on the field. That was since 2023, and in 2025, based on our experience, we have made the revisions. However, the color coding and all the format remains same. So for all the protocols, there are certain color codings. It comes with the title at the beginning. The blue bar is for your diagnosis. The green one is for you to do something. So there's intervention here. The yellow one is for your health advice. The red ones are for the emergencies, and the pink ones are for your targets and monitoring. So, and then this can be downloaded in a PDF format from the Ministry of Health website, and the link is given here. This is the protocol for hypertension screening and management. This was last revised in January 2025. I'd like to give one disclaimer here. So for this protocol, it is very clean, very simple. If you look into it, there are no theories, nothing. It means that this protocol is to be interpreted by health assistants or medical doctors who are already licensed, and you have been trained and you know what is hypertension, you know how to manage hypertension. But this protocol has been put in place so that to bring everyone onto the same board. So even if you are, whether you are HA or doctor, or whether you are in a primary healthcare center or in a national referral hospital, everyone should be following this. The second message, disclaimer, or second key important message through this is that even if the patient turns up at the national referral hospital or in a regional referral hospital, the care for hypertension or diabetes that you receive from this hospital is at a basic level. This means that, for example, these services are primary healthcare type of service. For example, even in GDWNRH, the care that you provide for MCH, like vaccination, antenatal screening, it is a primary healthcare level service, and that is the same standard that is being provided in any other primary healthcare center. So we would like to bring the management of diabetes and hypertension to a level such as this, so that patients in the patients across Bhutan get the same standardized care. Okay, now I'll explain to you the protocol. So for this protocol, every protocol has to be read from the beginning to the end. So from the title at the beginning is hypertension screening and management, which means that this protocol can be used for the nationwide screening programs or any screening programs that you implement in any ceremony, like wherever there's a wang or a major gathering, you're called for screening. So this is the protocol that you're going to implement on it. Every protocol will have a version number and a date. So in case if this protocol gets updated, it will be, you can know it from the version number and the date on the top. This protocol begins begins here, where it says that blood pressure should be measured as per standard, and you should have 2 readings 1 week apart. And whom should you screen? You should provide a screening opportunity for all adults more than 18 years of age. So that's why we had already discussed on how to measure the blood pressure in the early theoretical component. If the blood pressure will go on the right hand side, if the blood pressure is clear cut on 2 readings, it's more than 140/90, then you will initiate treatment. So you will jump to the green box where it says you'll have to do something. Delay. Now, if the blood pressure is less than 130/80, it means that the blood pressure is normal, and then you will follow this patient up with 6 monthly BP readings. And this means that if the patient was screened today and BP was normal, you will call the patient back after 6 months, and then you will keep on measuring it. So you'll keep on providing the opportunity for the patient to get, or for the client to get the BP readings done. If the blood pressure is between 130 above 130, but not 140, and between more than 130 and more than 80, but not crossing this level, then you will go to whether you see whether the patient has risk factors. If the patient has risk factors like stroke, diabetes, chronic kidney disease, or coronary artery disease, or if the patient is more than 65 years of age, then you will initiate the treatment. However, if the BP is slightly elevated, but if the patient does not, if the client does not have risk factors, you will go back and then they will be screened every 6 months. Whoever is having normal blood pressure or whoever is not getting labeled as hypertension, you will have what are the explanations or what are the interventions that you will do in your hospitals. You will always tell about lifestyle changes. Here, you will provide the brief intervention on smoking cessation. And then so for alcohol and tobacco, we always advocate for cessation to stop alcohol and tobacco consumption. Then based on the BMI, you can provide targeted, based on the BMI, you can provide the target based on your height. This is the permissible weight for you to be within the healthy limit, and then this is your target weight. So this is how you will provide your target for your weight reduction. For hypertension, you will provide what is a DASH diet advice. So to reduce salt intake 5 grams per day. So that's what we had discussed earlier, that 5 grams per day would come out from a half teaspoon, and then that has to be distributed all throughout for your on the whatever number of curries or meals that you cook for that day. You should always give advice or reminder on to reduce salt from other sources such as pickles, dry fish, or the processed foods, and then you should advise for adequate fruit and vegetable consumption. For physical activity, it is recommended that you should have moderate level of physical activity, something that increases your heart rate for a while, and then that would include some walking, jogging, for 30 minutes per day in a day for 5 days a week. In addition to that, you should always do a cardiovascular risk assessment and then intervene based on that. So the cardiovascular risk assessment is a separate session that I'll provide to you tomorrow or next day. Now, if the patient has been diagnosed based on this standard screening procedure as having hypertension, then it says initiate treatment. So what is the first line of treatment that you are supposed to provide? That is hydrochlorothiazide 25 milligram OD. So this is the standard first line recommendation that is recommended for all patients diagnosed all across the country. And this is the recommendation as of January 2025. Now, within 1 month of starting the treatment, you should, if it's in a big hospital, you do it in your hospital. But if it's a primary healthcare center, you refer the patient to a center to do this screening: fasting blood glucose, postprandial blood glucose, lipid profile, renal function, liver function, ECG. It can be a urine routine examination or urine albumin and fundoscopy. Now, this all will be done at a center where the facilities are available, and these reports are to be seen by the doctor upon its completion. Now, and then for the doctor, you will see the test reports, and then you will have to evaluate and individualize the treatment. This would mean that if the patient has no risk, no complications, this is the most common scenario that we have, and the patient is absolutely fine, BP was 100, around 150, then with hydrochlorothiazide, you have been able to bring it down to 130. It would mean that you would not add any other agent. If you would like to add any other agent, the second line is losartan. It will come down the line, but if there is no complications, please continue the patient on hydrochlorothiazide. Now, the reason why we are saying it is because we have to take our situational context into account. Hydrochlorothiazide is a drug that is easily available through all levels of healthcare center. There has been huge amounts of medicine that are already indented and available in the system. Now, there's no point, as per SCCI principles, prescribing something that is not available, and there's no point giving something that patient will have to struggle. For example, now if the patient is given amlodipine or some other medication, and if the patient will have to either buy it or ask his family members to get this medication from some other hospital, it is not good for the patient. So this increases the risk that where the patient will drop out of care. Therefore, at this situation as of 2025, We are looking into the advantages, disadvantages, risk, benefit, and then this is the recommendation. Now, from the secondary level care, the patient will come back to the primary healthcare center for the follow-up. So some patients, majority of the patients will get controlled with hydrochlorothiazide, maybe 25 or 50. And at the primary healthcare centers, if the blood pressure is under control or if under control, the health assistants are not supposed to stop any medications. If the blood pressure with hydrochlorothiazide is 120 by 80, it means that the pressure is under control because of this medication, and it does not give any reason to stop the medication. However, if the health assistant or at a primary healthcare center, if any clinician feels that there's need to stop the antihypertensive medication, this is the time they will call and discuss the case with the doctor, and then they can stop the medication. Now, at the primary healthcare centers, if the blood pressure is under target, so what do we mean by target? Our BP target is mentioned here. So 120 to 130, 72 to 80. So if your blood pressure is under target, then you can follow the patients up. If you are able to follow the patient up monthly, well and good. But if it's impractical for both the patient and the staff, then you can do it 2 monthly. But you are not allowed to go beyond 2 months or 3 months. Why? Because if you go to 3 monthly prescribing pattern, this will end up you'll end up losing opportunities where you could have intervened earlier, or this will directly impact your performance recording on your NCD dashboard. So if you record it 3 monthly, then most of your patients will automatically get classified as uncontrolled, and then your hospital will be performing very poorly. Now, if the BP is not under control with hydrochlorothiazide, then you can add losartan and follow up monthly until it is controlled, and then you can send the patient back to the primary healthcare center where it will be followed up 2 monthly. However, even with these two medications, if BP is not under control, then you can consult the higher center or refer the patient, and then from there they will optimize the medications and send the patient back to the primary healthcare center. This means that treatment of hypertension, uncomplicated ones, will have to be done at your hospital. So the reason why we ask you to do it is to make it more convenient for the patient and to keep as many patients under our care so that they have BP under control. Now, what are the very few group of patients that require specialist level of care? These are the ones with stroke, retinopathy, heart disease, somebody with raised creatinine or chronic kidney disease, proteinuria, or BP is not controlled with more than 3 medications, or if there are concerns for secondary hypertension. Therefore, to summarize this protocol, as long as your BP is under control, and for the majority of the patients, this can be the care can be provided in primary healthcare centers or in general or in district healthcare centers, or in the context of a referral or tertiary care center, the care can be provided through the NCD clinic or through the general OPD clinic. So there are very small subset of patients that would require a medical specialist intervention or a cardiologist intervention. So therefore, we have now, through this program, we have to pass the message that it is not always necessary to see a specialist for your hypertension or diabetes. In patients who are now, we are going to the red box here. If patients have hypertensive crisis at a primary healthcare center, here we don't want the health assistants to classify what type of emergency it is, but here we have labeled it as hypertensive crisis with BP of more than 180 by 110, and with any of the symptoms with seizure, altered sensorium, new headache, edema, shortness of breath, chest pain, paralysis of limbs, or pregnancy. These patients will have to be referred to the secondary level care, and then they will be evaluated by our doctor, and then they will have their treatments individualized. This means that there are a couple of ways for the patient to enter into our protocol. It can be they can be detected through a screening program, or they can enter through the emergency pathway, or where they present with an emergency. However, please be mindful that as much as we are trying to bring patients into the protocol and then trying to follow them up, if you recall, and then if you do not check your registers, or if the NCD focal person is not looking into any dashboard, then patients often fall out of this protocol and then you lose them and then they come back with complications. Thus, now coming to the bottom part of the protocol where we have mentioned the target. Now, if a person who has been newly started on hypertension medication, we target the recommended reduction of BP that you have to target is to reduce it by 20/10 per month. This means that you can be patient and then you don't have to be so aggressive in bringing the BP down in a couple of days. So you can, for the target, so you can reduce the BP by 20/10 per month. And ultimately, your target should be first, you will try to achieve 130/80. And subsequently, if things are going okay with this patient, you can try to bring them back to 120/70. You should recommend it yearly follow-up or within 1 week if the initial BP is 110, 160/100. You have to follow them up frequently. And for very old elderly patients, you may have to keep the target a little bit on the higher side based on their frailty. How do you monitor? We ask you to bring the BP under target within 3 months of initiation. You should monitor for the adverse effects. You should monitor for the adherence to lifestyle modifications, and these things can be done yearly: the ECG, fundoscopy, and urine albumin. So as of now, this is the protocol-based management for screening and management of hypertension. What does it not cover is that it does not cover how exactly to individualize the patient. Do you want to add furosemide, or do you want to add metoprolol or carvedilol? These things need to be, these things will come in the form of a separate guideline. And right now, what we are doing is actually for the full continuum from diagnosis till the monitoring of complication. This protocol takes very good care of the almost the entire spectrum, but this box, how to individualize it, is a very big chapter, and I think there's going to be a separate guideline for this. And then when the guideline comes in, this guideline will fit into here, and then we'll have a very clean set of protocol for management of hypertension in the country.